Disorders at Sheppard Pratt. And I'm joined today by Dr. Yang, who's our wonderful child and adolescent psychiatrist. And we're really excited to speak with you a little bit about the topic of eating disorders, the diagnosis, a little bit about the treatment, as well as early signs and prevention. So I will go ahead and pull up our slides. Can everyone see that? All right. All right, so I think that we did the introduction already, so I'm going to go ahead and get started. Dr. Yang, would you like to start?
Sure. Are you able to advance the slide by one?
Yeah, I think I am.
Okay, great.
Yeah, just let me know when you're ready.
Okay, we can move on to the next slide. So hi, everyone. I'm Dr. Yang. It's nice to see everyone here. I'll just jump right in and sort of start with what eating disorders are. So I think that the presentation is still stuck on the first slide.
Okay, I have the second one on my...
Technical difficulties.
All right, let's try this again. How about right now?
It's still stuck on the initial PowerPoint.
All right, well, let's see. Let's try again.
Okay, there we go. All right. So what are eating disorders? So eating disorders, I think, can be broadly thought of as any disturbance in eating pattern that interferes with functioning or health. So the main question it boils down to is this eating pattern causing any problems in my child? There are lots of different kinds of eating disorders, some that are related to body image and wanting to be thinner, but other kinds of eating disorder actually don't have anything to do with body image. You're probably all familiar with anorexia, which involves food restriction or food elimination in effort to lose weight. So there's two subtypes: restrictive, meaning the child is restricting food, versus binging and purging. And it's also further classified by BMI. So some kids with anorexia actually have normal BMI, and that's still considered anorexia. It's just considered atypical anorexia. But I would emphasize that it doesn't mean that it's any less severe or worrisome than the kids who have lower BMIs for typical anorexia. There can always be health consequences of any kind of disturbed eating or restriction. The second major type is bulimia, meaning using behaviors to compensate for food intake, such as intentional vomiting or purging, or over-exercising or laxative abuse. There's also binge eating disorder, which is characterized by uncontrolled eating of large amounts of food at a time. And then finally, there's avoidant restrictive food intake disorder, or ARFID, and that can be thought of as extreme picky eating. So avoidance of certain foods due to intense aversion of the taste, texture, smell, or other sensory components of the food, and typically doesn't involve any desire to lose weight or control body image. And of course, there's a great variety of eating disorders, and some kids can have symptoms of one or the other, and there's a general unspecified category to sort of capture all the other types. We can advance to the next slide.
Did it work?
Yep. So some background information about eating disorders. So they're very prevalent in the US and often begin in early adolescence when kids are undergoing puberty and body changes, because this often results in increased awareness and attention to one's body and how it fits in with what they see around them, as well as in the media. In general, more females than males are affected by a 10-to-1 ratio, with the exception of ARFID, where males are actually more affected. It's very worrisome when we're considering a child with an eating disorder, because it does have the highest risk of death among any mental illness, both for the reasons of the medical complications that can happen, as well as increased risk of suicide. Eating disorders impact everyone across all genders, races, ethnicities, and socioeconomic backgrounds. And here on the eating disorders unit here, we actually have quite a diverse patient population. And then during the pandemic, we've actually seen an increase in individuals struggling with eating disorders, likely because of the isolation and the sense of no control, which can certainly contribute to eating disorders. We can advance to the next slide. So what causes eating disorders? Much like a lot of other medical illnesses, it's what we consider multifactorial, meaning it's caused by not a single thing, but usually multiple reasons. So the first and foremost is that there is a genetic component for eating disorders. So people with a family history of eating disorders are more predisposed to developing eating disorders. Temperament or psychological factors of the child. So what we often see is a kid with a very rigid temperament or tendency toward perfectionism and wanting control, as well as environmental stressors. So sort of what's happened around the child or during the child's lifetime. And so some of the things we see include traumatic events, bullying, environments where there's a heavy emphasis on body image and competition, like certain types of sports or dance, as well as the attitudes of the people around them, whether it's peers or family, about weight and body image. So all of these factors can contribute towards the development of an eating disorder. Next slide.
So I will jump in. So I think what's really important is obviously the question that we'll try to answer is how we can be more on the lookout for possible signs of an emerging eating disorder. As Dr. Yang mentioned, things have become particularly challenging since the COVID pandemic and for a lot of different factors. Not only we've seen a lot of variables that contributed to increased prevalence, but also many of the kids and adolescents were less, so to speak, visible, right? So with virtual learning, virtual meetings, there was more opportunity for isolation and more opportunity for emerging behaviors and symptoms to be really unrecognized until things were pretty severe. That's something that we have seen here at Sheppard Pratt. Many of our adolescents that come into treatment are quite sick and typically more sick than we would expect them to be pre-pandemic. We also know that for many of them, the symptoms started even earlier. So as Dr. Yang mentioned, the typical onset of symptoms for most of our patients is around puberty. But I think with the added complication of isolation, pandemic, lack of control, or difficulty with access to food resources, and just increased stress, anxiety in general, we're seeing more and more children that start developing eating disorder symptoms much earlier, even before puberty. So there are some things that may point out towards the fact that the child may be developing an eating disorder. Like with everything, it has to be taken in the context, and it will not be a single symptom that will tell you, oh, my child has an eating disorder. It will be a constellation of different symptoms. So, and again, like I said, taking it into the context, a cultural context and familial context, if your family is used to eating regularly meals as a family, everyone together, and suddenly the child starts leaving early, stops finishing what's on their plate, even though perhaps they always did, or just start skipping meals, that could be an early sign. Or just isolated behaviors, right? So someone, an adolescent or a child who used to eat all the meals with the family suddenly takes their meal to their own room and does not want to eat with the family or in public. We often see this increased attention and involvement with meals, with cooking, with grocery planning. And like I said, some of that can be a part of natural maturation and developmental process and learning how to become more independent. For many of our patients, it becomes extremely compulsive, that there's this interest in new recipes, in healthy version of recipes. The child wants to take control over the entire meal planning. Things have to be done the same way. There's like excessive attention to weighing the ingredients, checking the labels, food labels, etc. For some, it's adopting a new dietary restriction. And again, right, taking in cultural context. If the family is at baseline vegetarian, then it's not going to be perhaps a huge change if suddenly the child decides to adopt a vegan diet. If we have a family who typically eats meat and the child who likes to eat meat, and suddenly they say that they want to eliminate all the animal products from their diet, that could be suspicious, again, especially if it's accompanied by the other signs and symptoms. And rigidity about around meals, they can only have this, they can only have that, it has to be done this way, it cannot be done any other way. And then signs of other behaviors, right? So potentially signs of intentional vomiting, or the child leaving the table and running to the bathroom right after the meal, or finding missing food that from the pantry or the kitchen, or finding the food wrappers in the child's room, could be also an indication that they're engaging in some disordered behavior, like hoarding foods or binging on food when no one else is around, and really isolating with that food. All right, and some other things. Obviously, I think when it gets to rapid weight gain or loss, or significant changes to the growth curve that can be seen by a pediatrician, obviously things are already a little farther along, and probably an indication that the child or adolescent have been already engaging in significant symptoms for a while. Again, that's something that we've seen since the pandemic, with decreased number of primary care visits. Many of those adolescents were kind of missed, and those changes to growth curves or weight curves were not noticed until much later. Additionally, we'll see more preoccupation with appearance, so frequent looking into the mirror, checking their body, pinching their stomach or thighs, or even arms and wrists, using a scale, weighing themselves even several or many times a day. That could be a good indication, as well as excessive physical activity, kind of beyond of what's expected, beyond of what they've done so far. Obviously, again, it has to be taken within context. If we have an active child who's involved in a lot of sports and does a lot of practicing between the scheduled sessions, it will be even more exacerbated. It will be more excessive. It will be compulsive, that the child will feel extremely nervous or anxious when they cannot follow through with the exercise that they believe that they have to do that day, or exercise despite injury. One may be told by their coach to limit certain type of activity because of some sport-related injury, And if they're unable to do that, and again, feel that compulsive need to continue to move and exercise, that could also be an indication for an eating disorder. And then kind of moving on to different weight loss apps, calorie counting apps, and just increased presence on social media and devices, especially exposure to pro-eating disorder sites and apps can obviously be one of the early signs too. All right, so in terms of what can the families and the adults at home do, we would recommend what we would call a positive food talk at home, right? So it's really this idea of trying to not vilify any foods and recognizing that all the different foods are good for us, and some of them are better in higher amounts and some of them are better in lower amounts. But all of them are okay. We cannot just completely exclude certain foods from our diets. Eating together as a family, as many meals as possible, can be actually extremely protective, and can help to prevent one from developing an eating disorder, as well as practicing normalized and mindful eating, right? So sitting together at the table, engaging in some light conversation, not in front of devices, not on the phones, actually sitting down at the table instead of standing or running around the kitchen or grabbing things on the go all the time. And again, right, taken in the context, there are situations where things cannot go that way and we're rushing between schools and sport practices and after school activities. But there should be an opportunity to sit down to have at least one meal as a family during the day. Avoiding dieting or talking about your diet, your weight loss plans, but while encouraging healthy eating, and a focus on positive body image and avoiding making negative comments about the changes of weight or changes in the teenager's body as they going through puberty. All right, Dr. Young, do you want to jump in again?
Sure. So early intervention is really critical given how serious eating disorders can become. So first and foremost, I would suggest doing your best to understand what's going on. So talking to your child in a very calm, non-judgmental way about how they feel about their body image and how they approach food and exercise. I think getting other perspectives can be really helpful as well. So talking to the staff or teachers at school about what they're observing at lunchtime or during gym class, and consulting with your pediatrician to make sure that there are no concerns medically in terms of a change from their trajectory on the growth curve, or any sort of indication that there may be more medical concerns, such as unstable vital signs or abnormal labs. Once that there is a diagnosis of an eating disorder made, it'll be really important to get a clinical team to support the family in managing this. And typically that consists of a pediatrician who can monitor the medical aspect of things, a dietitian or nutritionist to guide the meal plans, as well as therapists. So individual therapists for the child, as well as family therapists for supporting the family in managing this. And then it's always important to get a level of care assessment to determine what is the most appropriate level of services that would best suit the child. And I can go into a bit about the levels of care. So here they're sort of listed from least intensive to most intensive. So least intensive would be starting out with outpatient level of care, meaning you have those treatment members and you meet with them about once a week. And the gold standard treatment is actually family-based treatment. So meaning that the parents and the family direct meal times and enforce measures to help motivate the child to eat. So that's the first thing you would start out with. The next level of care is intensive outpatient. So typically that's 3 or 4 days a week, maybe 3 or 4 hours a day, usually involving group therapy to address and monitor the eating disorder symptoms. The next level of care would be partial hospital or day hospital program. So that's just an increase in the number of hours and the frequency of care. So usually it's anywhere from 5 to 7 days and all day, usually with 1 to 2 meals that are supervised at the hospital by a staff. Next level of care would be inpatient eating disorders. So that's what we have here at Sheppard. And that means that the child is residing in the hospital and the focus is more so on the behavioral and psychological interventions for treating the underlying eating disorder with a combination of individual and group therapies as well as monitored meal times. A lot of parents and families ask, well, what's the difference between the 2 levels of the hospital, between inpatient eating disorders and the medical hospital? And the difference is that the medical hospital is typically on an inpatient pediatrics unit to monitor and refeed the child in a safe way. So they purely focus on stabilizing vital signs, stabilizing labs, and getting the child to a safe enough weight so that they can do the behavioral interventions outside of the medical hospital. There is medical monitoring on the inpatient level as well, but it's more of a combination of the medical monitoring and the psychological interventions on inpatient. I think we can move to the next slide. Here's just like a list of resources that can be helpful, some websites, as well as 2 books that can help elaborate more on eating disorders.
All right, and I think with that, we can probably open up to questions. And just another resource for everyone, if you have any questions about our inpatient program or would like to schedule a level of care assessment, the best way to reach our admissions team is via email, and it's here included on your slides. And I believe the slides will be emailed to everyone.
Thank you so much, Dr. Gondek and Dr. Yang. This has been super informative. I know I've learned a lot, and I'm excited to open it up for questions and hear what other people are interested in learning and what additional information we'd like to share. I will get things started because I have a question about body checking behavior. You mentioned that on one of your slides. And as a mother of a 13-year-old daughter who is frequently looking at herself in the mirror and changing her outfits and, very concerned about how she looks, I'm curious about how much of that behavior is a normal part of adolescence and when is it over the line and where a parent would need to be concerned?
Sure, thank you. No, that's a great question, and really, it's really a broader topic of kind of understanding how all this fits in within the cultural context, right? So, oftentimes when I talk to my patients, I explain to them that some degree of distress over our bodies and weight and shape is actually normal for our culture, right? So we're constantly bombarded by this, through different media, and especially at the early beginning of each year and New Year's resolutions, etc. And part of that is normalized, and it's not until it gets to the point that one actually modifies their behavior, especially their eating related or exercise behavior, in order to significantly change their body, that causes a significant distress, that it turns into a disorder, right? So again, everything has to be taken in context. And it's really just looking for the constellation of different other symptoms that may be present, along with some of that, body checking behavior. I think to add to this, I think kind of realizing if there's an observation that this behavior become excessive, that the child spends like hours before they're able to leave the house because they keep on changing outfits, or suddenly change the way they're dressed, either in a way of wearing significantly bulkier clothing to completely cover their body, or actually expose a lot more of their body as a way of kind of showing off. We see that a little bit in our very underweight patients. So that would be something that will be of concern. But like I said, it's really kind of putting all those things in the context and kind of building a clinical picture based on a lot of symptoms. I would not be alarmed if it seems like that's only that this one single behavior that suddenly a young adolescent girl is more interested in the looks and more careful about what she wears and how she wears it.
Thank you. That makes a lot of sense. I see that we have another question in the chat. What does Sheppard Pratt's program offer for treatment? I know you mentioned that you do the inpatient treatment there at the Center for Eating Disorders. The other levels of treatment that you mentioned, are they also available at Sheppard Pratt?
Unfortunately, at this time, we only offer the inpatient level of treatment. But if you're interested in like a level of care assessment and it's determined that the adolescent would benefit from a different type of treatment, whether it's outpatient or one of those step-up levels, we're able to provide resources for that.
Great, thank you. So I just want to say to all of our participants, feel free to unmute yourself and ask a question if you would like, or if you prefer to drop it in the chat. I am monitoring the chat so I can read your question out loud. We definitely want everyone to get their questions answered today, so please feel free to jump in and ask while we have these great professional resources available to us.
Hi everyone, my name is Amanda. How are you? I have a lot of questions, but I think something that I wanted to start with was, you talked about that unspecified possibility for a diagnosis, but can we see an overlap in diagnosis in terms of maybe someone's restricting a lot and then they're still purging behaviors at times? And if so, how do you kind of determine between which one's more primary? And then with that, I'm also wondering about comorbidities. I think obviously something like anxiety, depression, possibly trauma. You were talking a little bit about like compulsive behaviors. I'm wondering about if OCD is a high comorbidity. So I'll start with all of that. Thank you.
Sure. So that's a really great question. And what I usually tell families is that these diagnoses are essentially our attempts to lump patterns and characteristics under a term, right? But in reality, we see patients with symptoms that sometimes overlap from different eating disorder diagnoses as well. For example, I think sometimes we have patients who come in with sort of more of an ARFID-like presentation with sensory aversions to certain foods and their textures and their taste. But also, after doing some treatment, start to realize that they also have some fears about weight gain and some body image issues. So patients, like people, are very unique, right? There's no one size fits all. And so I think the goal here is usually not to stress which exact diagnosis most perfectly fits with the child or the adult. But more so, what are the symptoms that are present and how are they impairing their functioning and how we want to address and help them resolve it. So I think that these diagnoses can be very helpful in sort of understanding the broader framework of what's going on. But again, it's not unusual to have patients who have symptoms from varying diagnoses. And along the same lines, it's, I would say, pretty rare to have a kid with just the eating disorder diagnosis. We get sort of everything else as well. Very common to see underlying anxiety, underlying depression, PTSD. You are correct in that OCD is another one that we see a lot of comorbidity with, and that makes sense because of the sort of rigid nature and sort of perfectionism that comes along with it. So we see oftentimes multiple comorbid diagnoses along with the eating disorder. And it's important to sort of understand everything that's going on and then try to address them appropriately in therapy and with medications at times, because oftentimes one condition also drives the other, right? I hope that helped.
I have a question.
That was
And
good, thank
sorry,
you.
I have a couple of comments on that. But unless you had like a follow-up question.
Nope, thank you, that was great, I appreciate it.
Yeah, and I think, you know, the other thing to keep in mind, and that's obviously more known to clinicians, is that eating disorders can be quite deceptive. So oftentimes we see patients who present a certain way to begin with, and they typically present with symptoms that are most distressing to them. And it's not until we get to know them a little more then we kind of are able to uncover some other underlying issues. It wouldn't be uncommon, and I see this more obviously in our adult patients, that they do not get diagnosed with an eating disorder until months or years of trying to seek help for different kinds of symptoms that are distressing to them. So, for example, with significant weight loss, there's a physiological body reaction, and people actually become more anxious and depressed as a result of malnutrition. So that the patients may be seeking help for depression and anxiety, while in fact they have this underlying eating disorder that really triggered the other symptoms. Additionally, medical complications. So for children and adolescents, thankfully, young bodies are quite resilient, and it takes a while before they experience significant medical comorbidities. But some older adolescents and young adults can get into this cycle of seeing their primary care doctor or different specialists for really dealing with different symptoms that are a result of an eating disorder until it's diagnosed that they in fact have an eating disorder. So that's also something to keep in mind.
Wonderful. Thank you so much for expanding on that. I'm going to try to triage our questions here so that everyone gets them answered. Allison Ford, I saw that you had your hand raised. So do you want to go ahead with your question?
I do. My daughter has eating disorder and she's self-harming. Started with the eating disorder and now it's self-harming. I just want suggestions on, I can't get her in therapy, waiting list forever. At what point do I need to say, okay, I need to get her in, what would qualify her inpatient?
Yeah, so inpatient criteria, I would say generally is based on either medical necessity. So if the child is demonstrating a significant amount of weight loss, if there are unstable vitals or low heart rate, or there are any medical complications, essentially, would probably push one towards inpatient level of care. Another criteria would be sort of safety. So if the child is so distressed that they're suicidal or they're self-harming significantly or they're engaging in other dangerous behaviors, could also be a criteria for inpatient level of care. But I think oftentimes it's a little complicated to answer because it depends on so many different factors. So I think if you're not sure, then I would pursue the level of care assessment.
Okay. Thank you.
So I see we have a question in the chat from one of our Maryland Coalition of Family staff who says she is working with a family who has a 17-year-old male who is incessantly lifting weights and obsessive behavior like weighing after a workout, going to the bathroom frequently. And this 17-year-old was addicted to heroin at birth, but has also experienced some bullying and body shaming behavior in middle school. And what sort of assessment might be recommended for this 17-year-old?
Yeah, so obviously we cannot really diagnose one based on this brief description, but there's definitely some concerning points that were noted. So I would say, starting with, talking with a professional, either the primary care physician or a pediatrician, getting recommendations, perhaps to see a therapist that specializes in eating disorders to get a better assessment of like what's going on, what's the underlying issue. And then, it may be easier to comment on what type of treatment or what level of treatment may be recommended.
Wonderful. Thank you so much. Another question we have in the chat is, once you are diagnosed with an eating disorder, is there a cure or is it actually a lifelong illness?
So again, I would say that it's similar to sort of any other medical illness. There are tools, both therapeutic and medication-wise, that can often help with treating an eating disorder. And many patients go on to do very well after treatment and have a remission of symptoms for the remainder of their lives. There's another subset who require multiple rounds of treatment, so sort of like a relapsing cycle. So, not uncommon to see someone who struggles with an eating disorder needing more intensive levels of treatment as an adolescent, does well with treatment, and then in early adulthood, there's a trigger or a stressor, and they start acting on their eating disorder symptoms again, and need another round of treatment. So there's no really clear-cut answer. We sort of see everything. We see some people who do really well with treatment. We see others who really struggle, and do struggle with it lifelong into their adulthood. So a broad spectrum of outcomes for sure.
Thank you. Another question that I have is kind of about, I guess, family or environmental factors that might, trigger eating disorders. I read that it's a myth that that eating disorders are caused by parenting styles, like very controlling or rigid parents who are very strict. I've read that that's actually a myth. But are there any kind of environmental or family factors that are particular risk factors for eating disorders?
So thank you for this question. It's a really great one, and it is true. Years and years ago, that there was like a circulating theory that it's the parents, and of course we always blame the moms that were causing eating disorder. That's not the case at all. In fact, now we know that families can be extremely protective. And one of the best treatment options, especially for adolescents and especially for adolescents with anorexia nervosa, is the family-based therapy that Dr. Yang mentioned, where the family really works together as a unit, has the same set of rules and expectations pertaining to eating, etc., and supports their child with healthy eating. It really comes with this idea that most of the families and most of the parents are able and know what to do to help their child and know how to feed their child. And that's really a very convoluted answer to your question, right? So there there are situations, right? So some extremely chaotic family situation where parents may just simply not be available, whether it's through their own mental health or other illnesses and issues or some other factors, and simply they're not able to provide the level of support that the child needs. So that will be one factor, and obviously unfortunate situations where the children are exposed to excessive alcohol or substance use in the family, excessive violence that kind of causes a lot of trauma, and depression and anxiety that can also be, unfortunately, one of the triggering factors. Like I said, other situations that are associated with kind of increasing chaos and instability in the child's life.
Right. Thanks. That makes sense. I see another question in the chat about what are the long-term effects of having an eating disorder?
All right, I guess I can take this one. So we've touched on it a little bit, I guess indirectly when we talked about the comorbidities that go along with eating disorders, and that's both the mental health disorders as well as the medical comorbidities. Obviously, those will vary a little bit from person to person, from disorder to disorder. But generally speaking, we're primarily concerned about the possibility of severe depression with safety concerns and suicidality. Dr. Yang mentioned in one of her slides that unfortunately eating disorders have the highest mortality rates from all the mental health disorders. And then there's this risk of developing extreme severe medical complications. I think it's worthwhile noting that even though eating disorders are psychiatric disorders, they affect all the body organs and systems. So literally every single body part and organ can be affected by an eating disorder, either because of the being severely underweight or as a result of extreme purging behaviors. The most worrisome are, of course, heart and cardiac complications that unfortunately can be fatal, as well as different electrolyte abnormalities that can lead to heart complications as well as kidney complications. But like I said, it can be a lot of different comorbidities, problems with the gut, with the stomach and the gut, skin problems, hair problems, problems with different blood counts that sometimes prompt their visits to hematologists, problems like dizziness and frequent headaches that may result in or even seizure that may prompt a visit to a neurologist. It's kind of what I talked about when I said that many of our patients are seeing a lot of different specialists for all those different symptoms that are in fact a result of the eating disorder.
Great, thank you so much. I'm looking in the chat. I don't see any new questions. What other questions does everyone have? Maybe we've answered all of them.
I actually have a question. Do we have mostly parents in the audience?
That is a good question. What's the best way to get a quick response to that? I guess raise your hand. Do the raise your hand or do the thumbs up. I guess I'm looking. I am seeing a lot of parents.
Okay.
Yes.
So I think I just wanted to point your attention to our slide with resources. The number one resource listed on this is for the FEAST website. It's spelled F-E-A-S-T, FEAST. It's an international organization that was developed by parents who have loved ones and children with eating disorders. for parents who have children with loved ones and eating disorders. I think as much as clinicians can be helpful, sometimes it's just easy to hear certain things from someone who's had the same experience, the same lived experience, and has been in the same situation. The Feast organization is mostly web-based, and that's how they're able to reach the entire world. They offer not only online and chat support, but also a lot of educational resources, including trainings, as well as different educational videos that can be extremely helpful to kind of understand and model the eating behavior, or how to support your child during the meal when they struggle, or kind of, again, talking about those different early signs and things that may be worrisome to you and how to respond to them. So I just wanted to say that that will be a wonderful resource. And Tiffany, thank you for putting it in the chat box.
Excellent. Thank you very much. That will be a great resource for a lot of people, I'm sure. What other questions do we have? We still have a few minutes left if anyone has anything else they would like to ask.
Could I ask a couple more things, ladies?
Sure.
I wanted to ask about two things. The AFRID or ARFID, I'm not sure if I'm saying that properly, diagnosis. We can see that, I'm assuming, even in really young children. I'm curious about, you talked about those sensory issues. Are there things that parents can do? I'm asking for my son who's kind of picky and has some sensory stuff that we can be doing to help with that sensory and like exposure to food, if we're not at a point of needing like therapeutic intervention. I'm not sure if it's actually like a clinical thing or him just being a little picky and wanting French fries every day. And then my next question was about denial of the diagnosis. If someone, I'm a clinician, so if someone, were to, meet a lot of criteria and there's a lot of concern about, disordered eating or a full-on eating disorder, do we see kids and teens kind of saying like, no, this isn't me, no, I don't relate in? And are there ways to treat it even if we don't have an understanding on the same page on what's going on, if that makes sense?
Sure. So I guess with the first question, I would actually, if you have any concerns about sensory issues, I actually would pursue an evaluation, because we want to understand if there's any underlying diagnoses or things that could be contributing to sensory aversions, right? And the question is, does it expand beyond just with food, right? Is it also with sounds, with light, with clothing? So I think a really thorough evaluation, you could even just start with the pediatrician to sort of report some of these things and see if they feel that a more thorough diagnosis would be helpful. And then I think in general with kids with picky eating, I mean, some of it's normal, right? So pretty much all toddlers are very picky and love mac and cheese and French fries. But I think we generally want to encourage a variety of foods, right? And with younger kids, what often is helpful is encouragement to try, at least one bite or a couple bites of something new or something they don't really like. And then, with the younger kids, using behavioral reinforcements like positive reinforcements can be really powerful. So those are some, I guess, initial suggestions. I know there's also a lot of resources out there for kids who are very rigid with what they eat in terms of parenting strategies. There are like books and websites. So I would look into that. The second question regarding denial of diagnoses. So I think that could happen with any age, like both kids and adolescents as well as adults. And it's not unusual because, sometimes they don't want to like acknowledge if anything's like a problem. So I think it's just working on sort of what their perspectives are, what they see as getting in the way of things. But obviously, if it's a more severe issue, the parents have to sort of take the reins and take the lead on getting the kid into treatment. So that's often something that is dependent on the child, sort of, what they see as the issue or impairment, and then what the family needs to do to sort of make sure that everything is adequately addressed.
Great, thank you. Amanda, did that answer your question?
That did. Thank you very much. But I just put into the chat, if you have any books or website recommendations for parents with any of this, but I was specifically curious about the picky eating and sensory stuff with the little ones. I would love to hear that. If not, that's okay too.
Thank you.
I would actually refer you back to that FEAST website. They also offer great resources for parents who have children with ARFID.
Excellent, thank you. Great, well, this will be, oh, I'm sorry, go ahead.
I'm sorry, Chair. I did have a question. My nephew just recently told us that he was bulimic. And the crazy part about the whole thing is we didn't know, and we're around him all the time. Like, how did we miss that? If that makes sense. I mean, if you're around a person all the time, I didn't see him going to the bathroom to throw up or any of that kind of stuff. So my question is, like, do they normally hide it? Like, is this something, I'm sure they're not going to say what they're doing, but it just kind of blew me away to hear that. We were doing a vision board, and then that's when he actually came out to tell us that that's what was happening with him.
Yeah, well, I'm really sorry that that's happening. I don't know if it's going to be reassuring or not, but it's not an uncommon scenario at all. And it's not, only the families or the parents or the loved ones that they miss the signs. It's even the clinicians. And that's why so many patients come to our attention so late in the process. And one is the deception that comes with the disorder. So yes, a lot of hiding, a lot of things that are not done in plain sight, but also extreme ambivalence towards treatment. Many of patients simply do not really understand how sick they are, how dangerous their symptoms are, that there's a certain degree of comfort and control that comes with having an eating disorder. And oftentimes it serves a purpose and they do not want to let it go. And like I said, sometimes it's not until things are pretty severe or they develop some serious complication, whether it's a medical complication or a psychiatric complication, that they are more willing to seek help or be more open about what they're going through.
Okay, thank you so much. And is there anything that I can do to help him? Like, that's another big thing. I see that you put that resource down, and I'm definitely going to, sign my sister up or somebody up so that they can help him. But is there anything that we can do that can kind of change that for him?
Yeah, I think, trying to have like an encouraging and open and non-judgmental conversation would be a great start. So that he can feel a little more comfortable sharing what's going on with him. And obviously, I don't know how old is your nephew, but encouraging treatment or looking into resources. If he truly has an eating disorder, like you will not be able to just help him by yourself. And I would really encourage you to try to seek help with professionals.
Okay, thank you so much.
Of course.
Okay, well, I see that we are down to the bottom of the hour here. I just want to draw everyone's attention to the chat. Dr. Yang and Tiffany have been posting some helpful links and resources in the chat. So please be sure to check that out and click on those for more information about eating disorders. I really want to thank you both, Dr. Gondek and Dr. Yang. This has been a fantastic workshop today. I know I've learned a lot, and I'm sure everyone else has as well. So again, thank you so much for being here with us today on behalf of Children's Mental Health Matters. And I just want to remind everyone that there will be a survey coming out about today's program, and we hope that you will take just a minute and participate in that so that we can get your feedback on today.